Shaban, over to you.
Doctor, can you just unmute yourself?
Dr. Shaban, can you unmute yourself?
Can you hear me?
Yeah, now
That is wonderful. Thank you.
Okay. So, Bismillah ar-Rahman ar-Rahim. Good evening, everyone. And in the time of United Arab Emirates, and it might be good morning or good afternoon in your timing. Thank you for having me today. It is my pleasure to be joining for the second time the cardiology webinar. And let me introduce myself. My name is Mohammed, and I am the clinical educator and the life support instructor in the Health Point Hospital. Today, my presentation, I will talk about something it is common happening, but with a less known with the normal people or like with the popular. We will talk about something it is hurting, particularly women who have like high sensitivity for the what happening around them, particularly from the close people or with any event it is happening with a sad event. So even the title or the name of this disease is kind of sad. So they call broken heart syndrome. So in women, and particular broken heart syndrome, it is happening more in women versus men. So we will talk today also about what it is the signs and symptoms, how it is happening, and what it is the proper treatment for that, and why in women it is more than men. So we'll start with Bismillah. Can you see my screen?
Yeah, we can see.
Okay,
can you
great.
shift to the full screen?
Again?
Can you shift to the full screen?
Yep. Okay. So at the end of this presentation, you will be able to differentiate between the heart attack and broken heart syndrome, define a broken heart syndrome, and identify the main causes of the symptoms, identify treatment, and identify the complication. So they call also, there is another term for this one, they call Takotsubo. Do you have any familiar cases with Takotsubo? Do you have been heard about that? Anyone? Please share with me. Do you hear about that before?
Yes.
Anyone here know about that? What it is Takotsubo? Or having
Yes.
like a knowledge about what it is the broken heart syndrome?
Yes.
Okay, great. So Takotsubo cardiomyopathy, it is by the name, it is a Japanese name. So TCM with abbreviation of TCM, it is a transient wall motion abnormalities. Let me make it the screen smaller so like I can talk freely with that. I can see all of the screen right now. So with more transient wall motion abnormalities of the left ventricles, apex combined with the emotional and physical stress that usually resolve completely. So we can see right now on the heart, in the left picture, you can see the normal heart, how it is the left ventricle appear, the normal shape of the left ventricle after contract with it squeeze. And we can see right now what it is the Takotsubo, the Japanese octopus spot. So with it will be like enlarged left ventricle, and the left ventricle will the form of the shape like an octopus spot. And you can see the apical balloons as well. So you can see how it is becoming enlargement in the way that it is cardiomyopathy, and it is look like the Takotsubo. So even I bring for you this picture with an echo, how it is really look like similar to the Takotsubo octopus spot. And why it is coming from that. So from the left ventriculophology during the systolic of the patient with TCM demonstrating such a shift. Now, what is the other terms for that? Now, there is also another terms. They call it broken heart syndrome, stress-related cardiomyopathy, transient left ventricle apical ballooning syndrome, a broken heart syndrome, and ampulla cardiomyopathy. Okay, so keep in your mind this one. It is discovered in the 19th. So with the Japanese doctor, and in 2006, the American Heart Association included these diseases under the class of acute cardiomyopathies. So with TCM, symptoms were considered extremely rare until the past 20 years. So before it was rare. In my opinion, it is rare, but like, you know, the science, it is progressing fast, and like with this progress, they found that like it is doubling and increasing the number. So with the increasing number of the medical reports of the symptoms has highlighted the higher incidence of the TCM than the previously reported. Further, 90% of this patient were post-menopausal women. Few reported indicated that there is average of age of the TCM patient was 68 years old, although children, young adult may be also affected. And from my side, I also encountered some kind of this patient. Another report indicated that the most men with TCM were inpatient, which suggesting that the physical stress might play a role in the progress of this disease. Good. So the most common presenting symptoms listed in the diagnostic criteria are chest pain and dyspnea. In rare case, patient develop palpitation, nausea, vomiting, syncope, and cardiogenic shock. So how we can finding the ECG changes until now? So till now, do you have any questions? Is it clear? Any question there? Okay, silence meaning that it is something that is going well. Now, you know, it is really tough or hard to find to distinguish between the STEMI and TCM. Really, it is hard. And even I research a lot about this one. I bring for you one of the recent research to find like there is a small point that we can distinguish, and it is not all of the time. So let's see right now. The ST segment elevation can be found mainly in a precordial lead in a 50% of the patient at the onset, and in addition, precordial ST segment depression in the inferior wall lead is unlikely, is comparing with a patient with a base deformity. Inverted T wave are more frequent, observed in patients with the apex balloon like dilation and the resolving spontaneously within a few weeks to several months. Furthermore, patients with TCM usually presenting abnormal Q wave in a precordial lead. This Q wave are transient in most patients and generally resolve within a few days to several weeks. Okay, I will show for you right now, next slide, what it is the anatomical variants. So you can see right now what it is the like an apical with or without MLV variant, like 75 to 80, mid LV it is 10 to 15, inverted 5%, and like as what you see right now, biventricular it is clinically less than 0.5%. If I will say right now about reported what it is like, how it is, what it is the trigger there, it is at the beginning, it is because of the emotion, highly range because of the emotion. It is even exceeding 60 or 70% of that. So with the emotions like death of a loved one, including pets, even pets, you can believe, even pets, like also it is leading sometimes for this one. Surprise parties with some people who have highly sensational and highly emotion, it can be, but this is really rare, okay, because mainly coming with a sadness more than happiness, okay. Family member being arrested, fires argument, robbery, and public speaking. Even with the public speaking, also it is less comparing to the other thing. With the surgeries, hysterectomy, cholecystectomy, stress echo with the dobutamine, also sometimes it is reported, opiate withdrawal, and thyrotoxicity. Now, what is the pathophysiology for that? Coronary spasm or or stenotic myocardial. So non-favorite wall involvement extended beyond single vascular territory. Few patients demonstrating spasm with a provocation during catheterization, and with the other one with the microvascular environment certainly presenting and yeah, with catecholamine cardiotoxicity, plasma level in epinephrine or norepinephrine increase even higher than in patients with or similar heart failure, not uniformly presenting. Oops, sorry. Okay, not uniformly presenting, but close histological findings similar in the other forms of the catecholamine cardiotoxicity. And I'm sorry, 1 second. Somebody want to say hi for you? Somebody want to say hi? Yeah, go.
Hello.
I'm sorry for that, but like she keeps knocking the door, so I'm not concentrating. Yeah. Now, so transient coronary occlusion or perfusion episodes, some investigation observed that the transient left ventricle dysfunction can be caused by the atheromatous rupture plaque, that it is not clearly visible, or coronary angiography. Okay, or exercise stress. Also, it is happening sometimes directly, like in response and direct concentration, and as a result of catecholamine provoking microvascular change. And also, this is an important thing, relative deficiency of estrogen. So estrogen deficiency may be responsible for the development of TCM, and show that the ovariatoxomized rats were more prone to a stress and demonstrate a higher increase of the heart rate and reduction in left ventricular function when comparing to the rats that it has had estradiol supplementary. So postmenopausal women lose the protective effect of the estrogens, which make them, this is an important, which make them more prone to excessive circulating catecholamine. Now, so we will focus about the estrogen. Estrogen may also play a role in the enhancing the beta adrenal receptor sensitivity and promoting vasodilation. Postmenopausal women have decreased beta adrenal receptor responsive for catecholamine stimulate than the younger female, and for that reason, I starting with the presentation about usually it is happening more with the like old ladies comparing to the younger ladies. So like even if we will compare more on women than male, so you can believe right now, as I mentioned, like more than 70 to 80% there with the female, and comparing to only like 8 to 10, maximum to 20% of the male. So there is more beta adrenal receptor stimulation in relation of beta adrenal receptor responsive the thought leading for more vasoconstriction, which it is a setting of the endothelial dysfunction may trigger the TTC. So whilst in men, this is the one, male are better protected biologically against the stress. and also I attached the resource for that. Sorry, for metabolic theory, estrogen has also been implicated in maintaining appropriate glucose uptake for the cardiac energy. Female heart depend on the glucose as it is energy source more than the male heart. The relative lack of the estrogen as women age, therefore, may potentiate the attitude glucose uptake, thus predisposing postmenopausal female. So male are not predisposal to TCC despite their relative lack of the estrogen. Okay, and make it a little bit big. See the screen. Because they are not as dependent on the glucose on their preferential cardiac energy substrate. So what is the ECG abnormalities? As I mentioned earlier, you can find an ST elevation usually in the anterior leads for more than 82%. Anterior lead, all of us we know, lead 1 AVL V5 V6, and for the ST depression, T wave inversion with a Q2 QT prolongation and abnormal Q wave. As I mentioned earlier, with the Q wave, it is indicated that there is ischemic or the history of the heart, like diseases happening there, but it will be disappearing within a few weeks to month maximum. So this is one of the ECGs that I compared for you, the two ECGs, the upper one and the lower one, with the right side, how it is like with the percentage. So like we can see right now in the ECG changes, ST segment elevation, most commonly in precordial leads, as what we see 46 to 100%. Diffusing deep symmetrical T wave inversion, and I also putting for you the lower ECG. You can see this one, it is clearly there, and pathological Q wave is what we see also there, and prolonged QT and interval. It is obviously here, and prolonged BR interval, and we can see this one clearly. So, what is the treatment? The treatment again, either conservative treatment or prophylactics, but what we can see right now, they will also depending on some kind of medication based on the patient case. So for example, the patient that with a severe left ventricular outflow tract obstruction with a hemodynamic compromise, treatment with the beta blocker or alpha adrenoreceptor agonists such as phenylephrine and volume expansion should be considered. Calcium channel blockers can be used to decrease left ventricular outflow tract pressure gradient. It is of the utmost important to avoid the treatment with a nitrates or inotropic drug in these cases. For patients with a suspected vasospasm, the use of calcium channel blocker such as verapamil or dilatilzim is suggested. Hemodynamically stable, for the patient with hemodynamically stable, like she have only palpitation or chest pain or like heaviness, but her vital signs, it is like we can say it is like stable. So are often treated with the diuretics, angiotensin converted enzyme, ACE inhibitor, and beta blockers to reducing the risk of the thromboembolism. Patient with a less of motion with the LV apex should be treated with anticoagulant therapy, again anticoagulant therapy, until the contractility of the apex it is improving, unless there is a differentiate contraindication. And this is my references. Any questions?
Well, all what I can say is we as females are so special.
You are so, no, excuse me, I am again at this one. You are not special, you are super special, not even special. You are super special. You know what? To be honest, like this topic, again, I am life support instructor. My specialty in life support, in ACLS and pulse, and even in my master dissertation, which it is even in published, how to make it like a BLS effective in the hospital setting. With the ACLS also I'm doing right now with the RQI. My main focus, it is life support, but this topic, it is really touching my heart. And whenever that we say that it is broken heart syndrome. Come on, guys, like be gentle, please. Be soft to those ladies. Be lovely to those ladies. They deserve. Really, they are. Without them, we cannot live. Without the females, we cannot live. Not only for that, no, for everything. For the emotion, for the food, for the even for the smile. We cannot smile without them. Can you believe like all of the world will be men's? What the kind of this world?
And it's if it's not our estrogens that make our blood thick, it is our hearts that are broken. It's not fair.
I agree with you 100%. For that reason, whenever that like I'm dealing with the ladies, particularly old ladies, only geriatric like I am touching. They are touching my heart. You know, all the gentility of the life, I will give it to them. All the smooth, all the kindness, I give it to them. But whenever that I'm dealing with the guys, I'm so tough.
Al-Nur, you want to say something?
Yes, thank you for the presentation. Nicely done. I may have missed it, and if I have missed it, I'm sorry that I'm asking again. What is the mortality of patients with this syndrome?
Great question. Thank you so much.
Number one, and then what are the factors that predict the mortality?
What are the factors that, again, what are the factors?
What are the factors that show you that that patient is at high risk of mortality?
Okay, thank you so much.
What are the markers?
Actually, I like your question. What's your good name, sir, again?
So what are the markers of high risk?
No, what's your name? What's your name? I cannot see you.
My name is Al-Nur Abdullah.
Mr. Al-Nur Abdullah, thank you for your question. Actually, I was expecting this one. The mortality rate there, based on the American Heart Association journal, we can, it is there, say, it is reported between 2.8% to 6.8%. You can, even if you are interested, I will email you with these references. 2.6% to 6.8%. This percentage, it is like, again, it is happening not only in US, this is worldwide. But American Heart Association, whenever that they are reporting, they are more focusing more in US rather than the other countries. So this is the mortality rate. And again, sir, if there is like a quick intervention and close observation, it will be like, for sure, this number will be minimized if there is a proper, and even the mortality rate will be decreasing, and morbidity, for sure, it will be very less. Now, what is the predisposing factor, or what is the factor that it is affecting? They say poor nutrition. Poor nutrition, it is also affecting, particularly if they are not taking the essential, the food elements like calcium, magnesium, potassium. It is an important for the heart also. If there is an extra using of the sodium as well, if there is also extra like electrolyte imbalance, extra using of the potassium, also there is a risk of the marital status. So they say the marital status, if the lady, she is in a poor community that, and she is single for a long life, or losing her husband, or like with a withdrawal for a long time, it is also a risk for her. Why? Because you know the sensation for them and emotions, it will be high comparing to the others. Also, they say based on the previous history, particularly the ACE, okay, acute coronary syndrome, or ACS, acute coronary syndrome, it is also having a risk for that. If the patient, she have multiple TIA, okay, it might be also a risk for them. So this is like what it is the most common thing. Plus, like as I mentioned for you, the important one with the emotional stress. If the patient, she is in the environment with a high stress, because of the security regarding her country security, or the war, or the economic security as well. If for that reason we find like if they lost their job, or husband lost their job, it is also indicate loss of the death, because of the death of one of her son. All of this one, it is like kind of the increasing the risk of the TCM. Yeah.